Thank you everyone for joining us for the Oley Foundation webinar, Short Bowel Syndrome and Diet, What to Eat, What to Drink, and Managing the Balance with HPN, sponsored by Takeda Pharmaceuticals. Our speakers today are Laura Matarese, Maria Karimbakas, and Carol Ireton-Jones. Their contact information is here on this slide. If you want to write it down, it will also be available in the chat function. My name, is Julie Andalina, and I'm a program associate with the Oley Foundation. Most of you are probably familiar with Oley, but just in case this is your first experience, I'd like to briefly introduce the organization. The Oley Foundation strives to enrich the lives of those living with home nutrition support, both intravenous nutrition, sometimes called HPN or TPN, and tube feeding. We do this through education, outreach, and networking. I'd like to go over a few housekeeping details before we get started. There we go. So you should see a toolbar at the bottom of your screen. You can use the chat function to send a message directly to myself if you have a question or concern. In the Q&A function, also at the bottom of your screen, please type in any questions you have for Laura, Maria, or Carol. Please note we will not be responding to the hand raising function until the Q&A section of the webinar. We will answer as many of the questions as possible during the question and answer period at the end of the presentations. We will post a recording of the presentation after the webinar on the Oley website. Please note that we have muted all participants, so you don't need to worry if there's background noise when you're sitting into this webinar. If you're having technical issues, please go to the Zoom website at the bottom of your screen here. And now, without further ado, it gives me great pleasure to hand it off to Dr. Laura Matarese.
Well, good afternoon, everyone. It certainly is an honor and a privilege to be here today and to share the virtual podium with such distinguished speakers. We are going to talk about what to eat and drink, and I am specifically going to address what you should eat. Next slide. So the photograph on the right is the standard American diet. It's very high in sugar, high in fat. And if you have short bowel syndrome, can you imagine eating this way? I mean, maybe you would like to eat this way, but more than likely consumption of a diet like this will cause increased output. Next slide. So the question becomes, how do we tip the scale so that there's increased absorption and decreased output? Next slide. Well, diet is the foundation of therapy, and the nutrition prescription must be based on the remnant GI anatomy in order to enhance absorption. And interestingly enough, it's also the most potent stimulus to intestinal adaptation that we have. Next slide. So this chart shows the two different nutrition prescriptions. And I really have to credit our colleagues, Teresa Byrne and others. Maria is also on this paper, by the way. And they did extensive research looking at absorption, whether your colon was in circuit or not. So if you look at carbohydrates, if your colon's in circuit, it should comprise 50 to 60% of total calories. Without the colon, 40 to 50%. But it's not just the amount, it's the type. And when your colon is in circuit, you do have to limit simple sugars. If your colon is not in circuit, in other words, you have an endostomy, you need to restrict these simple sugars. Protein is the same for both groups, about 20 to 30% of total calories. Fat, yes, you do need fat. Now, if your colon is in circuit, it should be 20 to 30% of total calories. Without the colon, it's a little bit more generous, 30 to 40%. But in each case, they should be primarily essential fats. Soluble fiber can be used. It's best to get it through diet, but at times you can use a fiber supplement. Meals should be spread out, small, frequent meals throughout the day. And if your colon is in circuit, you do need to limit the oxalates because you're likely to form oxalate stones. And I'm going to leave the fluids to Maria, who will be addressing that in greater detail. Next slide. So what do we mean by simple sugars and complex sugars or carbohydrates? When we say limit the simple sugars, we mean things like actual table sugar, candies, cakes, cookies, pies, regular soda pop. Here in the South, sweet tea. So all of these sweet things create a hyperosmolar load to the gut. And as a result, water rushes in to try and dilute it, and you get diarrhea or increased ostomy effluent. On the right, you can see the complex carbohydrates. The chemical structure is much larger. So things like pasta, potatoes, bread, cereals, whole grains is tolerated, and some fruits and vegetables is tolerated, are generally well tolerated by somebody with short bowel syndrome. Next slide. So you can use artificial sweeteners. So things like Truvia, Splenda, Sweet and Low, Equal. So the pink stuff, the green stuff, the blue stuff, the yellow stuff are all okay. You do need to limit the sugar alcohols, however. And you can recognize these by the OL at the end, and you'll see it on the label. So things like sorbitol, mannitol, xylitol, these things are poorly absorbed, and they will create abdominal pain, gas, bloating, diarrhea, and in anybody, but especially somebody with short bowel. Next slide, please. Next slide. Okay. So protein is really an important component of the diet, whether your colon is in circuit or not. And you want to have proteins that are good proteins, high biological value proteins. These tend to come from animal sources. Whey protein, of course, is very high biological value protein, but things like meat, fish, poultry are also very good. It's not to say that you cannot consume vegetarian types of proteins, but the biological value is not as great as proteins from animal sources. Next slide. Essential fatty acids, yes, we all need fat in the diet, and it's best if you can consume the fats that are on the left side of this graph. These are high in the essential fatty acids. And once again, it's not to say that you can never have butter or whole milk and cheeses, red meat, but these really need to be limited. Next slide. So what about fiber? You know, fiber is one of those things that if you have diarrhea, it tends to bind things up and firm up your stool. And if you have diarrhea, it tends to make you go. With short bowel syndrome, you're going to want to choose the soluble fibers. And the foods that contain these soluble fibers are listed on the left. You can also get these from soluble fiber supplements. The insoluble fibers you need to limit. And these things generally are not easily digested by somebody with short bowel syndrome. And those of you, for example, that have an ostomy, if you consume the foods on the right, you're likely to see bits and pieces in your ostomy bag. Or if your colon is in circuit, you're likely to see it in the toilet bowl. Next slide. So the types of foods and the way the food is consumed affects your absorption. Next slide. Again, from Teresa Byrne and colleagues, they looked at the types of diets that enhanced absorption in short bowel. And both of these diets have 2,400 calories, 50% carbohydrate, 20% protein, 30% fat. If you have short bowel syndrome, you want to be on the left side of this screen. Notice there's breakfast and a mid-morning snack, whereas the typical American diet has 8 ounces of orange juice and a cheese and fruit-filled Danish. That's probably going to cause increased output. Next slide. And for lunch, you can see the difference. Next slide. And finally, for your evening dinner and a little snack, the diet on the left is really more likely to enhance absorption with short bowel syndrome. The diet on the right will cause increased output. Next slide. So putting this all together, plan a balanced diet, include these complex carbohydrates, proteins, and fats at each meal, avoid or limit simple sugars, distribute the food throughout the day, chew your foods well because digestion begins in the mouth. Use salt liberally, especially if your colon is in circuit. That will enhance absorption. And most importantly, we not only eat for nutrition, we eat for the social value, for the pleasure. So enjoy your meals with family and friends. This concludes my comments. I'm going to hand it over to Maria.
Thank you so much, Laura. I too feel honored and privileged to be part of today's panel. So thank you for inviting me to join. I am going to be speaking about what to drink. Next slide, please. So diarrhea is the primary consequence of short bowel syndrome. And of course, that has many consequences. One of the most important consequences is that it can lead to dehydration. So one of the most important things that you're going to want to do is focus on your oral fluids, and you're going to want to avoid drinking oral fluids in a rapid manner. Certainly your body is going to require more fluid when you're dehydrated, and you're certainly going to feel more thirsty, but drinking oral fluids quickly will typically worsen circumstances by causing, more output, in some cases, some vomiting, but really it's the more output that gets you caught in a pretty vicious cycle of more thirst, which of course then leads to more of the same. So it's really important for you to be on the lookout for the signs and symptoms of dehydration and work with your healthcare team to develop the best treatment plan, which sometimes can include additional IV fluid and possibly enteral fluid through a tube if you have one, and may of course include some additional oral fluid as well, but always being very careful about how much you're drinking at any one time. So when we think about dehydration, actually prevention is the best treatment. So we're going to learn about that today. So next slide, please. So it's really important to choose an appropriate oral fluid that's tailored to your bowel function and anatomy in order to best manage your fluid balance. And you may not know what that fluid is. So we're going to be learning more about that today. Then it's important to drink an appropriate volume of the fluid slowly throughout the day to meet both your baseline needs, as we call it, and also to cover all the losses from the increase in stool output. And so this is probably, I think, one of the biggest challenges for short bowel consumers, because it's not as natural to pace yourself all through the day to drink your fluids. So that's an important concept, and one that really has to be somewhat learned. We all usually drink a lot more frequently in response to thirst, but when you're thirsty, you're already dry. So that's an important point. And the fluids used to provide hydration are based on the type of fluids and electrolytes that are being excreted in your body. So in some cases, electrolytes may need to be added to these fluids. So the fluids that we're going to talk about in a moment are supplemented with things like sodium, because that's the electrolyte that's lost in the most in stool, potassium in some cases as well. So these fluids have that. And then there's a balance of glucose or sugar, as well as sodium together to help get them absorbed as optimally as possible. So although we're choosy about sugar, we don't want you to overdo the sugar. There has to be some present in order for the salt to be adequately absorbed. Next slide, please. So in order to sort of understand the concept of the fluid, we're going to just talk a moment about osmolarity. So that's the number of osmoles, or the number of particles per liter of solution. More simply, we're just talking about the concentration of fluid. So the more particles there are, the higher the osmolarity or concentration. So why is this so important? It's important because simple sugars, which are found in both food and in beverages, cause an increase in the concentration of intestinal fluids due to their very small particle size. And this results in an increase in diarrhea, malabsorption, and loss of fluids. So it's really important to understand where the sugar is coming from in your diet, and to be really selective. And I know Laura just spoke about that in regards to food, and replacing some of that sugar with sugar replacements that are available. And now we're going to focus on it as in regards to beverages. Next slide, please. So there are three types of fluid that we need to be aware of. There are the hyperosmolar fluids, and these contain many particles of glucose in little to no sodium. They cause fluid to be pulled into the intestinal tract to dilute the concentration of the drink, causing watery diarrhea. So examples of hyperosmolar fluids include juice, soda, and smoothies. Hypoosmolar fluids contain few to no particles of glucose and sodium, so they're not concentrated at all. So they're not always absorbed entirely. You may also hear them referenced as free fluids. Examples include water, decaffeinated beverages, and sugar-free beverages. And then there are the isoosmolar fluids. These contain sodium, potassium, and glucose in the same concentration as the blood and extracellular fluid that surrounds the GI tract. So they won't cause fluid to be shifted into the GI tract and actually aid in their absorption. And this is where our oral rehydration solutions fall in this category. And this is where you want to focus. Next slide, please. Okay, so I just want to highlight, when you're looking at these tables below, that the normal osmolarity of the blood plasma, and that's the liquid component of blood that surrounds the GI tract, that number is between 275 to 295. So our hyperosmolar fluids range in this table anywhere from 550 all the way up to 1265 in the prune juice. So as the sugar increases, the osmolarity increases. And so if the fluid that you're drinking has this very high concentration, the fluid surrounding the GI tract is going to come rushing in order to dilute that sugar. And that's where the diarrhea stems from. The hypoosmolar fluids have very little osmolarity, as you see here, 0 to 18 milliosmoles per liter compared to that 275 to 295. So they don't cause a rushing of fluid into the GI tract, but don't get particularly well absorbed. And when you drink lots of it, especially water, over short periods of time, it can lead to diarrhea. It's the isoosmolar fluids, iso meaning same, that share close to the same concentration as the fluid that surrounds the GI tract. So as you see here, ORS salts, these are just examples of types of rehydration solutions that pretty much match the osmolarity of the fluid around the GI tract, and therefore are most adequately absorbed. Next slide, please. So when thinking about wanting to focus on the oral rehydration solutions, here are some examples of products that are appropriate choices within this category. So there are commercial products available, those that come in packets that can be mixed in certain portions of water based on the package instructions. Things like Cerealite, Drip Drop, Pedialyte, Rehydrolite. There's a product made by Janus Brothers that mimics the original recipe of the World Health Organization. There's also a newer product called Trioral that is a reduced osmolarity formulation of the World Health Organization's recipe. So these are all, again, commercial products available and are appropriate to implement, but certainly we would want to reroute you to your medical team to be sure that, for example, if the solution contains potassium, we want to make sure that that's appropriate for you, for example. So you want to be sure that you run this all by your medical team. Now, if your preference is to make a recipe at home, there's a few ways to do that. These are just a couple of examples. There's actually lots of ways. And many of you, I think, have seen Carol Reese Parrish's book that references many recipes that include a couple here, which is the G2, which is Gatorade, the reduced calorie Gatorade. So there's just enough sugar in that recipe that it doesn't require dilution. And to that, you want to add a half a teaspoon of salt per 4 cups or a quart. If you're looking to use a fruit juice as the base, you can get a 3/4 of a cup and mix that with 3 1/4 cups of water and then add 3/4 of a teaspoon of salt. So there's lots of ways to go about this, and it's just imperative that you focus on finding a solution that you can enjoy and commit to, because this is really a key part of the short bowel plan. Next slide, please. Okay, so I'm going to hand it off to Carol, who's going to talk about managing the balance. Thank you.
Okay, thank you, Maria and Laura. You've done an excellent job talking about what to eat and what to drink. So now I wanted to talk about managing the balance and putting it together, because I hope that you are hearing now that what you eat and what you drink does matter and makes a difference in how you feel and your output. So even if you are receiving parenteral nutrition, and that's the basis of your nutrition and your fluids, if you can eat, you may want to eat. So let's talk about how to manage that balance. Could I go to the next slide, please? So it is a balance. It is a balance of your parenteral nutrition, your IV fluids, and then what you eat. So I thought Laura mentioned the typical American diet. As you can imagine, that might be something that would increase your output and not be well tolerated. While if you eat some of the other things that she mentioned, you would have a much better outcome. So let's go into the specifics. Next slide, please. So managing the balance. If you're receiving parenteral nutrition daily, you receive daily multivitamins and minerals and your electrolytes. So you may just be taking in oral nutrition for the flavor, for the fun, for being with your family. You may not have to worry about if it's a lot or a little. You may just be doing this for the satisfaction. However, if the time has come where you are decreasing your dependence on parenteral nutrition, say you are beginning to wean, or you have gotten to the point with adaptation, as Laura mentioned previously, that you may need parenteral nutrition only 5 days per week, then that is where managing the balance with your oral or enteral nutrition becomes very important. So that is, on those off days, you won't receive your multivitamin and minerals that are in your parenteral nutrition. Now, if you're eating food, or if you're receiving an enteral nutrition supplement or tube feeding, then there may be vitamins and minerals in those. But if it's an oral diet, then you have to consider that this would be the day to take a multivitamin mineral supplement. Next, then you have to think about what your absorptive capacity is. So could you take a chewable vitamin, or will you need a liquid vitamin, or can you take a tablet? not only during these days, or is it the vitamins, vitamin A, B, the B vitamin, C, etc., but it's also the minerals such as calcium. So with the calcium, will you be taking a calcium supplement that is a tablet or something that is chewable? These are things that come into play when you're beginning to manage that balance. Second, also, then, as Maria talked about, is your fluid. So is your parenteral nutrition providing nutrition or IV fluids? So those 2 days that you were off, are you using IV fluids, or are you trying to balance with oral rehydration solutions? So be very attentive to what Maria mentioned when using oral rehydration solutions to replace the fluids that are lost. In fact, you may do a liter of hydration and then take 1 liter to 2 liters of oral rehydration solutions, as she mentioned. I have several of these here on my desk that are easy to use and take with you as well. So you could use some of these. And then finally, with the diet, will we need to modify that for absorption? Laura provided what many of us absorbers would be a pretty high calorie diet. So that was around 2,500 calories. But remember, you as someone with short bowel syndrome may not have the absorptive capacity that someone with an intact small bowel would have. So you may have to eat more calories in the form of fat, carbohydrate, and protein. So certainly one thing you do need is a dietitian during this phase to help you manage this. So that is a way to manage the balance between oral or enteral, whichever that you are doing, and parenteral nutrition as you either wean off or you wean off a couple of days. Now, you need to monitor this. And so that could be a calorie count. Again, this may be something you've never had to worry about. It doesn't matter the calories in the food because I've always been covered. So in that case, again, working with a dietitian can help getting just a visual of how many calories are in like a protein serving or carbohydrate serving. Managing your fluid status and monitoring your fluid status. Is your urine output the same? Are you having at least 1 liter or maybe 1.5 liters per day? Are you having much more than you would expect? What is the color? Is it darker? Is it clear? Do you need extra calories? Is there other output? So you think you're doing well with your intake, but you notice that certain foods increase your output, then that's where you need to potentially modify what you're taking in, whether it's your ostomy output or your GI output. But what I want to say here is do the best you can and work closely with your team and certainly your dietitian, because if you've never paid attention before, now is the time. Next slide, please. So we want to turn it over to you for questions, but I'd like to leave you with these takeaway messages from Maria, Laura, and I. Diet is the foundation of therapy for short bowel syndrome. Yes, you may require parenteral nutrition and or enteral nutrition, but also diet is extremely important. Fluid and nutrient absorption can be enhanced when your oral intake is based on your GI anatomy, so we know what you can tolerate. So what you eat matters, what you drink matters, and this can be a very successful opportunity for you. All right, so I am going to turn it back over to Oley and Julie, and we are going to be available to answer any questions you have. Julie, you may already have some questions for us. So if you would like to start with those, that would be great. And Laura, Maria, and I are here.
All right. Thank you so much, all three of you, for these fantastic presentations. And yes, as you said, Carol, we will start taking some questions from the audience. I am going to stop screen sharing here so we can see our three panelists. And I'm going to start by looking at some of the questions from the Q&A. So first question, and anybody feel free to answer. You all are fantastic in this field. So are sugar alternatives such as monk fruits, stevia, and agave able to be digested in shortcut?
So I'll start with that. Stevia is fine if you have short bowel syndrome. So any of the artificial sweeteners such as stevia, Splenda, Sweet and Low, Equal, or OO are all okay. I would not suggest you do things like monk fruit, agave, or even honey, because those things still are simple sugars and will probably cause an increase in output. Maria or Carol, if you want to add anything, please jump in.
I do, because I think that many of you are probably trying to be more healthy. And what could be more healthy than using natural honey or agave? But actually, honey has much more fructose in it than does plain old sugar. And so it's actually not more healthy for the GI tract because it can actually cause increased output. Also, just to make you feel good, all of these artificial sweeteners, except the sorbitol and mannitol containing ones that you mentioned, Laura, all of those have been highly, highly researched. So they are safe ingredients and safe for you to use. If you don't want to, you don't have to, but they are safe.
And kind of going off of that note, you mentioned honey is natural and naturally sweet. So is there such thing as too much natural sugar, maybe in like whole fruits, things like that? Should those be limited as well?
So yes, that can happen. And I have worked with short bowel patients for 3 or 4 decades now. I've never seen two that were exactly alike. So it's, in a way, it's a dose response, because some people can tolerate a small amount of fruit and others cannot. So I would be cautious. Here in the South, especially now, it's watermelon season. So you may be able to tolerate a slice or a cup of watermelon, but you can't sit down and eat the entire watermelon, because that's probably not going to go well for you and increase your output. So Maria or Carol, if you want to add to that.
Well, Laura, I'm in the South too, down here in Texas. And a slice of watermelon is, you slice it and it's the size of your plate. So that really, if you've ever been to brunch and they give you that cute little piece of watermelon that you think that is not enough, that's a serving. So
well, things are always bigger in Texas, I know.
It's true. But so I just wanted to mention that a serving size is, and I always keep these at my desk, around a cup to a half a cup. We should give these out at the next Oley meeting when we're together, don't you think?
I think so.
So you could measure these.
I actually do hand out measuring cups for some of my patients who don't have them.
Definitely. And I was just going to add, Carol, to your point about, of course, fruits are healthy, right? So, and we're pushing the American diet to eat more fruit, but the way the bowel sees fruit is sugar, and the sugar, unfortunately, in fruit, it is the same way the bowel sees, unfortunately, a candy bar. So, gram for gram, the bowel does not discern between where it came from, its source of sugar. So it really is just so individual in terms of the response that you have. And so although your efforts to add fruit may be for healthful reasons, unfortunately, the bowel doesn't see it that way.
The other issue is the fiber that's in the fruit.
True.
So again, you may be able to tolerate small amounts. So if you're eating a fresh orange, you may be able to tolerate 2 or 3 segments or even half the orange, but not all of it. So, just watch the amount.
Mhm. Great, thank you. So this was a question that was in the chat function. Are spring water and mineral water okay to drink? And that goes for still water and carbonated water as well. Do those have any difference from regular tap water?
In terms of the osmolarity, no, they also fall in the hypoosmolar category in terms of their concentration. So the bowel will see those the same. So we don't say no to those things, but just that the majority of your fluid should come from an oral rehydration solution. And I typically recommend having smaller servings of those other preferred beverages at, say, with pills or at mealtime, or if you're not separating your food and fluid. So finding ways to weave small amounts of it in so that you don't get completely tired of the rehydration solution, but it shouldn't be the prime source.
Excellent, great, thank you. Next question is, how do you determine the quantity of fluid you should be drinking per day?
That's a great question. I can jump in on that initially and then have others add in. It really is based on a number of things. So you would be wanting your medical team to tell you it's based on, first body size, what your output already looks like, what you're doing for physical activities, because we lose fluid through our lungs just by breathing, but certainly through our skin when we sweat, both, in warm days in certain parts of the country, it's, many parts of the year, as well as just, like I said, breathing. So you need to be told how much fluid you should be consuming. And then in some cases with short bowel, more is not better. So, in some cases, we actually limit the amount of oral fluid if you're someone in which fluid, even at lower levels, stimulates the bowel to the point where it leads to some dehydration. So it really is something we don't say like across the board. In general, an adult, I could say 2 quarts of an oral rehydration solution is not an unreasonable amount. That's sort of a usual go-to number, but that number does not apply to all. Does anybody else want to jump in on that?
Maria, a question I get, and I'll let you handle this because I know what my answer is, but what about the sodium in these ORSs if you're getting older and you're thinking you need to limit your sodium? And then Laura, also the same about sodium, we're real liberal with it usually. How does that affect a short bowel syndrome patient that might have maybe some cardiac issues or some swelling? Would you guys answer that for me? That has come up.
Yeah, sure. Again, real individual. I think that if the sodium, if it's a blood pressure issue, then that has to be taken individually. I find a lot of times with short bowel, the blood pressure issues, especially if there's a lot of weight loss that occurs post, getting the diagnosis, if you weren't born with short bowel, tend to go away. So sometimes if you're on medications for blood pressure, often those are removed as time goes on. But with the salt, you really do need more, because depending upon how much your losses are, if you're putting out, a couple of liters of stool a day, your sodium losses are significant. So we usually, I tend to not limit unless there's a proven, reason to limit. And when it comes to edema that we sometimes see, we often see it for other reasons that are not salt reasons. It's sometimes it's more nutrition, low protein, or maybe too much IV fluid being given. So I don't point at the sodium usually first, but Laura, what do you think?
Yeah, I agree. I rarely have to limit the sodium. I think if your doctor says you need to limit it, then yes, you should. But most short bowel patients actually need additional salt. And they may need it in their fluids, as Maria had discussed. But I also find that salting their food fairly liberally helps with absorption. Now, you don't need to salt it to the point where you can't eat it, but, most short bowel patients actually crave salt. So where, other Americans, they eat way too much salt, but the short bowel patients actually need a little bit of salt. I have not experienced short bowel patients with high blood pressure that needed to restrict sodium. At least not so far, but maybe tomorrow. So, Carol.
Yeah, I would say the same. And then when I am working with a short bowel patient and ORS, they're not getting a whole bunch of salt at one time because we tell them to sip it and take your time over it. So I've always thought, well, if you're gulping down that, just because you may or may not be trying to get through it because you're not crazy about the flavor, but if you're sipping it, then you're not getting that much. And it's also a vehicle for absorption rather than, as we've talked about, something right on top of the food. So I think for all of these things, that lends itself to positive use of the sodium salt.
So Carol brought up a good point about sipping your oral rehydration solutions. I think that's really important rather than gulping them. One of the tricks that I have learned and recommend to patients is to put your oral rehydration solution in ice cube trays and then take it out when it's frozen, and then it's almost like a slushy. You do not want to add ice to the oral rehydration because then that dilutes the concentration. But if you put it in an ice cube tray and sort of freeze it, then you can have a little slushy.
That's right.
And to add to that, also if to make popsicles out of the rehydration solution is a great option too, to help slow down the quantity that you're drinking at any one time. It can help relieve some of that thirst, so that you don't overdo the fluid in one sitting. So some people find that a decent strategy as well.
Well, on the topic of fluid intake, is there drinking black tea or black coffee, is that good, bad? Should we limit the amount that we drink of those fluids? Any recommendations there?
So I'll start with that. If your colon is in circuit, so you're having bowel movements through the rectum, you have to limit oxalates so that you don't get oxalate stones. And tea and coffee are high in oxalates. Now, caffeine, that is in tea and coffee is a GI stimulant. So it will, if you drink too much, you'll have a bowel movement or you'll have an increase in ostomy effluent. So I have my patients limit their intake of coffee and tea. Now I get it in the morning, sometimes you just have to have that cup of coffee, but I would really limit it. You cannot sit down and drink a whole pot of coffee. That's just not a good idea. Carol or Maria, you want to add to that?
I ditto.
I never touch
I-
anyone's morning coffee, but beyond that.
Right.
Yeah.
That's right. That's right. And I mean, I don't know how coffee tastes with a teaspoon of salt in it. Just kidding. But that really, we are trying to have as much as possible. If you're short bowel syndrome, your fluid is the ORS. So you pick that thing. If it's your chamomile tea, if it's your cup of coffee, it's your Diet Coke. Okay, that's your thing. If it's your what is we were talking about mineral water here or whatever, that's your thing. And then have whatever your dietitian or healthcare professional recommends. I usually say a cup and then try for the rest of it to be an oral rehydration solution.
And does drinking decaffeinated coffee or tea make a difference, or are they similar to regular caffeinated coffee and tea?
It should make a difference. In other words, you could probably get away with decaffeinated tea and coffee because caffeine is the GI stimulant. But a lot of these so-called decaffeinated beverages are not 100% decaffeinated. So again, I would be cautious of the amount. But that would be better than regular coffee or regular, teas that have caffeine.
And Laura, the oxalates don't change in that too, right? So the oxalate.
Oh, that's true. Good point. Thank you. If you are trying to limit your oxalates, yeah, the tea and coffee, whether they're regular or decaffeinated, should not be consumed.
I would just like to mention something that has been new to me as I've been looking at many different ORS packets. In the good old days, our ORS packets, especially some of them that we've known for a long time, were pretty pure. But I'm finding caffeine and probiotics and things being added into the ORS. So I think that Oley keeps a really nice list online. I think Maria presented a really nice list. So be careful because, I mean, SBS patients are drinking this, but also all those athletes are drinking this. And so they're all excited to get a cup's worth of caffeine thrown into their ORS or whatever. So be careful with additives.
Good point.
And we've had this question a couple of times. What does it mean when your colon is in circuit?
So forgive me for not explaining that in greater detail. But there are some people who have short bowel syndrome and, because of surgery. So they may have had some resection on their small bowel and their large bowel, but the surgeon puts the small bowel and the large bowel together and you have bowel movements out the rectum. As opposed when the colon is not in circuit, maybe it's totally removed or the surgeon has left it in the abdomen and just doesn't want to hook it back up. Those patients have an ostomy, an ileostomy or jejunostomy. That means the colon is not in circuit.
Great, thank you. Very helpful. Is there a difference in the type of salt used, whether it's kosher salt, sea salt, or regular table salt in the short bowel diet?
I'm going to start with this one. Now there are all these fancy salts, sea salt, pink salt, Himalayans, all these fancy gourmet salts. You should try and get a salt that has iodine in it. And that's the important point. Salt is salt. It's still sodium chloride, whether it's pink or, some fancy salt, but it needs to be iodized. And you can buy iodized sea salt. So, it's out there. Carol and Maria, do you want to add to that point?
No, I agree.
That is true for every person. So if you are short bowel syndrome sitting next to your partner who is not short bowel syndrome, they're all the same, guys. Pink salt is not better for you. It's pretty, but it is not better for you. If you like bigger pieces, then get kosher, but you just, Laura hit the nail on the head. You got to look for iodized salt. And I didn't do that for a while because I was into all the different salts. And then suddenly I was like, oh, I think I've had iodine for a little while. So I don't know what happened to me, but I guess I didn't get deficient because I ate out enough. But that's just such a good point.
Mhm. Thank you. Does, this is for anybody again, does eating more calories by mouth increase output?
So that depends on the type of calories and the amount. So if you are eating lots of candies, cakes, cookies, pies, ice cream, that's going to increase your output. If you consume foods that have complex carbohydrates that are low in the simple sugars, and you spread it out throughout the day, you're likely to absorb more.
Yes, the
Maria,
distribution is so important. I just want
Yeah.
to emphasize exactly what you're saying, Laura, is just, you know, what you're choosing first is important, and then how you distribute it throughout the day. And relative to the meal plans you were showing, some of the problem, you know, the fat, the protein, and the carbohydrate were equal on the whole, but how it was distributed throughout the day is what was disproportionate, and why the diet number 2 would not be as well tolerated as diet number 1 in those slides. So such a key point.
Yeah, so grazing is good for you. You know, snacking throughout the day is good for you. Where most Americans, we don't want them to snack. But if you have short bowel syndrome, you want to snack throughout the day. Okay.
And I will just add on the sweets that I have, it's been hard for me so far in my career to find a short bowel syndrome person that isn't crazy about candy, cakes, cookies. Somehow sugar is a biggie, and salt. So if you could eat your meal or snack first and then get a bite of what that is, if that's a fabulous piece of cheesecake, just have that bite or two of it. But you've maybe had your complex carbs first or your mix first, then go ahead. But making that the basis of a snack, or saying, well, I've got 200 calories, I'm going to have that. It does increase your output. So just our whole thought is what you eat and drink matters. So that's a way to combine it that may give you a sneaky way to get that.
So I agree very much with Carol on that point. And if you can combine carbohydrate, protein, and fat all together, that would be best. And as Carol was saying, you know, that little bite of cheesecake, that's my idea of cheating. So I give my patients cheating guidelines. I mean, we're human, and, you know, food is important, and you like your sweet treat. So, you know, you have a piece of cheesecake, you have one bite, and you give the rest to your partner. And that way you can satisfy your sweet tooth, and, you know, not increase your output.
All right, it looks like we still have quite a few questions coming in, and only a few minutes left. Is it all right with you three ladies if we run over a little bit, or
Sure.
if that's okay? Excuse me. What was I going to ask next? Okay, yeah. So do you have any suggestions for increasing oral intake in patients who are TPN dependent or tube feeding dependent?
I would say what we have presented here today would be excellent, but it might not be that 2,500 calorie menu that Laura mentioned, but take that breakfast and then decide, well, what sounds good? I mean, I have my oatmeal right here, but so maybe you want to make a small amount of oatmeal, and that's the first thing you try. And then for lunch, you make a half of a sandwich, or so I think it's just really, if trying. I have a consumer right now that I work with who didn't eat for 23 years, and she's only been eating for 7 years. But so that's kind of interesting because she didn't have 30 years of different foods. So she's now trying things out and knows what things that she ate in her early years that she never wants to have again. So I think it's trying to give the guidelines that we've done, but then you don't have to eat a lot.
Yeah, and view every bite as success, truly,
Exactly.
that, is just as you're saying, Carol, it doesn't need to be a lot, and to reward yourself on, if this is all still new, it's every little bit. Anytime some food passes through the GI tract, you're doing something beneficial for the short bowel. And so being choosy about what you select, and then being proud of yourself for the little bit that you did and tolerated is a step in the forward direction. And
I
so,
agree.
that's all we can ask, really. I mean,
Yeah.
it's hard when
Remember,
you're not to eat, and you're just getting to it.
food is the most important stimulus to intestinal adaptation. So we have always allowed our clients to eat on home TPN. Small amounts and throughout the day, and that stimulates the bowel. So that's a good thing, but it has to be smaller amounts and more nibbling.
So kind of in that same area there, if maybe someone is struggling to tolerate the foods that they're eating, and we kind of touched on this throughout, what are the food groups that might be tolerated better? Carbs versus sugars versus proteins. Are there any recommendations in that area?
So I'll start out. The complex carbohydrates are usually well tolerated. But these are things like breads, pastas, cereals, but the ones that are sort of lower in fiber. Proteins, if there are the softer proteins like fish or poultry, are also well tolerated. It's the fruits and vegetables that most short bowel patients have some difficulty with. And some of our recommendations are kind of contrary to what we would recommend for the average American. So for example, one of those big soft pretzels with the salt on top that you get at a baseball game, those are really well tolerated, okay? And sometimes, I have had some clients who just can't give up their Coke. I'll have them say, okay, you can have a little bit of Coke, but you have to have it with one of those big soft pretzels with the salt on top. So you create almost an ORS, and the complex carbohydrate of the pretzel will help. Maria or Carol, you want to add anything to that?
No, I think that I guess the only thing I would say is just eat, no matter the size of the meal, just trying to get, just as Laura was just describing, a combination of food so that you have, versus saying, any one, macronutrient is better than another. The combination of them is what the bowel wants to see together. If there were one that's tolerated the best by the GI tract, I would say it's the lean protein. I mean, that's the steady thing in the diet that we really don't have too many caveats to speak of. Lean protein across the board is very well tolerated, and that's why we would love it at every meal and snack. Most people are used to adding protein at mealtime, but not at snack time. So inserting that lean protein at snack time, even if it's just a small or much smaller portion of the meal you just ate, you know, if you had a sandwich at lunchtime and you do a half a sandwich as a snack, you know, that would be great. Or pairing, I always, my favorite go-to is a hard-boiled egg, you know, throw a hard-boiled egg in to, even with that pretzel, you know, just to balance it.
And I would just add that you have short bowel syndrome. So you might need antidiarrheal agents. It's not a failure to eat and need a medication. We're hoping that we can help you with these great suggestions, but if you need an antidiarrheal agent, if you need something to slow down the fluid excretion, that's okay. Because you're a short bowel syndrome patient consumer. So it's okay to work through those. So talk to your doctor about what those would be, and know that what I might take for traveler's diarrhea might be a third of what you need to take with your GI anatomy.
And there's still quite a few questions. And it looks like we're kind of on a roll here, so I'm just going to keep going for now. There are a few questions about sources of calcium and other vitamins, using Tums as a main source of calcium. Are there other suggestions, other foods or over-the-counter medications that you would recommend?
The citrate form is a little better absorbed, but I think people really like the Tums for the ease of being able to chew them.
I'm sorry, what did you say? The what
I
form?
have them here.
I love show and tell. You've got everything. So the citracal form, or the calcium citrate form of calcium.
So
versus
it kind of,
carbonate.
the way I think about it is that, I mean, this is just 200, I think, milligrams, and you need around 1200 or more, especially, Laura, you might address this in with oxalates. So, I mean, these, if you're a good pill swallower, and if you know that your pills are broken down and absorbed, that's great. But that's when these Tums, and there's other chewables, you just have to be careful with what's in them. There's nothing, this is calcium carbonate. There's nothing else exciting in this, even the flavor. And this can be somewhat constipating, and you may like that.
So I tend to recommend calcium citrate because the absorption is better. If you want the Tums, then you need to consume those with a meal, because when you eat, there'll be acid production, and the calcium carbonate is absorbed better in an acidic environment. And the calcium citrate, though, is my number one go-to. I mean, it can be a generic calcium citrate, and the pills tend to be bigger. So if you have trouble swallowing them, you may have to, you know, cut them in half or something. And the point that Carol mentioned about oxalates, for those of you who need to restrict oxalates, and they may be in some of your favorite foods like berries and coffee and green leafy vegetables, cocoa, those types of things. An alternative method is to consume additional calcium, which will bind the oxalates. But it's a fair amount. You need probably about 3 grams a day to bind the oxalate.
And just to, oh, sorry.
Oh, no,
Yeah.
Julie, I was just going to say, I thought I saw a question come over just in regards to the why of the oxalate, and I'm happy to jump in on that.
Oh, good.
So it's for those with a colon, they're the ones, those that have colon intact they're at risk for the calcium oxalate stones. Not that you absolutely can't get them if you don't have your colon. You can have a different type of stone, but they're you're more prone to. And the reason that is that the calcium is what ends up happening in the GI tract is that the calcium that's normally available in the diet is getting bound up to the malabsorbed fat, making it not available to bind to the oxalate. And so oxalate is passing freely into the colon and getting absorbed. And then getting absorbed into the system and getting excreted through the urine and making you more prone to the stones. So the extra calcium, as Laura is suggesting, in the diet or through supplementation can help fill that void and help bind up some of those oxalates. And so I much prefer, because it's hard to limit everything in the diet. You need the calcium also for your bone health. So it's why not take the calcium for the bone health and to bind up the oxalates. It's kind of the killing two birds with one stone thought. So.
And to just add 3 opinions here, I don't start out with oxalate, limiting oxalates with anybody. I there's so much that you have to do that I kind of wait to throw out oxalates or and limiting that until I hear that there's a challenge, I have to say. So you guys might start earlier with your patients on that.
And I would agree with that too, like trying to get them on the bigger challenges right first, ORS, cutting sugar, kind of I have my priority list unless they come to me with stones as being their front running issue.
Right.
Yeah, I agree totally.
Just quickly, you mentioned your priority list. Can you just say like, what would be the first thing you focus on? Is it cutting sugar? Is it ORS? Is it, what to focus on first?
Yeah, I mean, for my priority list, I think of ORS being right at the top with sugar. I think getting the hydration under control the most quickly is the thing that's going to keep you out of the emergency room. That's so getting hydration under control, because weight and regaining of weight takes time. And the TPN is there to help with that, but that's not a 911. The fluid and the electrolytes are the 911s. So that's where I place my emphasis for a patient that's really either new to the diagnosis or is really struggling to keep out of the emergency room.
I agree totally. And I will tell my clients, you can live thin, but you can't live dehydrated.
Oh.
So yeah, focusing on the sugar and the oral rehydration, I think is a top priority.
And it may sound like oral rehydration. Okay, drink enough water with salt in it, great. We're working on your kidney. We're trying to save your kidneys. We're talking about ORS and short bowel syndrome, but our goal is to keep your kidneys healthy. So that's really why we focus on adequate hydration with something that we know is absorbed. It's kidneys. So you can live thin, but if you're well hydrated, then you'll live thin with your good kidneys.
And I also, absolutely. And I also think, sometimes, and this should not be viewed as a failure, that sometimes part of the plan is additional IV fluid. As much as we want the oral rehydration solution to be in place and work for you, and we will keep working towards that goal, sometimes the implementation of some IV fluid to break the cycle and to replete the kidneys and to get, better function and less thirst, it's just necessary. So really don't view that as a failure if you or the one you're caring for needs some additional IV fluid here or there. That's also a strategy to stay out of the ER, right? You can stay, if you're someone at home on home therapy, like parenteral nutrition, then you should not be in the emergency room with dehydration. We should be able to manage that at home with IV fluid if needed.
Totally agree.
Yeah, I'm really glad you said that too. And I think, Carol, you had mentioned earlier that needing supplements or needing hydration isn't a failure. And I think that is so important for everybody here to hear and understand. So thank you for addressing that.
Absolutely. We think of the nutrition support continuum for this population, and at different times you need a different combination of things. So it's be very forgiving to yourself. This is not an easy diagnosis.
I think I will just ask this one last question that a few people have hit on here, and then we can wrap things up. The question is about nutritional supplements and formulas such as Ensure or someone mentioned Pediasure peptide. Do you guys have any recommendations on what over-the-counter supplements might be better absorbed or tolerated? Or if something like real food blends or blended diets might be tolerated better?
My answer to just kick it off is I need to talk to you. So I think we have to be very individualized, but I think one thing that we have said clearly is limit the sugar. And that is the problem with many supplements, is they are higher in sugar. So there's some higher protein ones, but again, I need to talk to you. I don't know. I can't just across the board make a recommendation for a short bowel patient. I might could for somebody who's trying to gain weight to be a better runner, but I need to talk to you. So I think my thought would be individualized.
And I know it's difficult to gauge a baseline. As you just said, it's on an individual basis, but what would be considered a lot of sugar to consume?
I have,
Go ahead.
oh, no. I was going to say, I have it's not written anywhere. It's sort of from my practice of, I think of more than 10 grams of sugar per meal or snack as being high. So kind of looking at the formula that you're drinking, I think that, I always say that these formulas, there's nothing magical about the calories. It's just calories. So if your preference is to drink the calories, then those are fine to implement. If needed, if you're trying to, say maximize overnight hours through a tube, or, you find it just easier to get liquid in than solid food. But a calorie is a calorie. So, just keeping that in mind, because some people think, well, I have to implement a supplement, and that's not necessarily the case. So that's one important thing. And then the diabetic formulas, maybe if you're having an intact solution, which if you're eating food, my bias is always to keep the supplements intact, because you shouldn't need a hydrolyzed formulation if the food is being tolerated. And that is how our GI tract wants to see it, is in the whole form. So that's why if I'm going to lean at all on a supplement, or someone really wants a supplement, then I usually go towards the diabetic formulas, like a Glucerna or a Boost glucose control. And those are just two examples. I'm not sort of married to either of those brands, but those are just examples of what I need.
And I agree totally. Food is best. If you can consume real foods, that is best for the short bowel patient. If you feel you must have a supplement, an oral supplement, then one of the diabetic supplements would be an okay choice. But I would rather see you have a half a sandwich, cheese and crackers, a hard-boiled egg, something like that.
All right, we are now 15 minutes over. So I would like to say, oh, hello, Joan. Joan Bishop has joined us.
Here's Joan.
Hi. Good afternoon. I want to thank all of you very much for a very enlightening session here. I think it's most valuable for all of the short bowel syndrome consumers to learn more about what's good, what isn't, and how to manage themselves. So I learned something every time I hear you speak, whether it's individual or as a group. And I wish we had planned for 3 hours here. I just wanted
to know that everything turns into food. Every conversation turns into food.
I know. And it's not just within this community, it's outside. I've been eating through the entire session, but I'm glad you couldn't see this and my choices. I just wanted to jump in here, and I wanted to acknowledge Julie, who planned this session. It's her last official task as an Oley staff person. She's been absolutely wonderful such a pleasant addition to Oley's staff. We've enjoyed every minute. We know no one ever leaves Oley, as these three ladies can testify.
Yeah.
Your titles may change on and off, and we kind of keep you moving from here to there, but you're always with us. And we know that, Julie, you're not going anywhere because we're not allowing you to do so. But we wish you well as you advance your learning. And this has been a fabulous, fabulous session. And we thank you for this and for everything.
Yeah,
Thank
thank
you.
you,
Pleasure to be a
Joan,
part
so
of it.
much.
Yeah.
Thank you, everybody here. Yeah, thank you three, Maria, Carol, Laura, for participating. This is so enlightening. And I don't think I said it beforehand, but for any attendees here, yes, I'm on the Oley staff, and I also have short bowel syndrome myself. So this is a very personal topic for myself as well. And I found this whole thing very, very informational. So thank you so much for all of your expertise and being willing to be here today. So yes, just to wrap things up, if questions weren't answered, Maria, Carol, and Laura's bios and contact information are in the chats, and I believe they're also on oley.org. The presentation, the webinar will be on oley.org along with the slides, hopefully in a few days. Oley also has some short bowel resources on our webpage underneath the resources tab. And there's so much great information on there. So, we highly encourage you, check it out, do some reading, ask some questions. We are always available. We try to make ourselves available to help you guys out. So again, thank you to our speakers. Thank you, Joan, and thank you, Andrea, for helping me coordinate this whole thing. You've been so super helpful. And once again, a thank you to our sponsor, Takeda, because otherwise we wouldn't be able to coordinate this webinar. And thanks to the participants for joining us today. This was such an informative webinar. I think we can all agree.
Take care of yourself, Julie. Congratulations on good luck on your next
Thank you.
adventure.
All right. Thank you so much. And this session is recorded and will be available shortly.
Thank you all. It's been a pleasure.
Absolutely. Thanks again.